Hi, this is Brian Kim. I want to share with you this case of a patient with a 3+ dense lens and zonulopathy. And so I'm going to show you how I'm able to detect zonulopathy and hopefully convince you why you should start polishing the posterior capsule, because those are related. And then lastly, I'm going to show you how I'm using a Sinsky hook to minimize torsional stress on the capsular bag when placing a CTR into the capsular bag. So here's the lens. I'm using a cotton tip to steady the eye and using a corneal marker, which will help me to center and size my rhexis. And then I make a paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I actually prefer to make an incision that's actually longer than it is wider. This is intracameral lidocaine and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. Holding the eye with the cannula, this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then I enter. This is a very controlled way to dictate the length of my incision. This is the sharp tip Halti-Perkar forceps. I'm going to puncture the center with the forceps. With the teeth closed, I'm pushing the tear towards me, grabbing the edge of the tear, and now creating a nice flap going around circumferentially and using the corneal mark that I made to guide the size and centration of the rhexis. I like using these sharp tip forceps because they act like a cystotome as well as a Capsulorhexis forceps at the same time, and it's a low profile forceps. Remove the viscoelastic, and then this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, decompress on the left side, pushing BSS and sweeping the anterior capsule on the left side again, doing the same thing on the right side as well, making sure I'm getting nice separation. In this case, the lens is not moving quite freely. I'm being very gentle. Whenever I notice this, it makes me a little concerned that there might be some zonular laxity. And so I want to be gentle in these cases. I don't try to be too forceful when I try to turn the lens in this situation. I'm trying to separate the lens from the capsular bag as much as possible nonetheless. Irrigating the surface of the eye, adjusting the sleeve, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, place the chopper under the rhexis edge with the tip pointing towards the periphery, sliding, getting under it, and then supinating my hand, making it vertical. You can see I'm performing the double chop, but the lens actually tilts sideways, but that's okay. All the forces are still in the center. It's not causing any traction on the zonules. And then this is a cross chop where I place the chopper around the right heminucleus, and I'm able to fracture that lens completely in half. Using some vacuum to pull that first quadrant up a little bit, getting around it with the chopper and then crushing it into smaller pieces, and then using some vacuum to grab some more pieces, crushing it between the instruments, and then emulsifying the lens pieces. So again, in this case, the lens tilted a little bit, but again, that's not a problem because it's tilting within the capsular bag. It's not having any translational movement of the lens. It's not moving to the left or the right or up and down. It's just pivoting and rotating within the capsular bag. And of course, because there is epinuclear material, there's no problems to the zonules. This is very safe. I'm placing the chopper around that second quadrant, pulling it centrally toward the fingertip and crushing the lens between the instruments. And then I'm able to crush it again using successive crushing forces and then emulsifying the lens piece. So the first two quadrants are out. I'm going to very carefully and gently rotate that second heminucleus in front of me. I can tell that the zonules are a little bit loosey-goosey on me, but that's okay. I slide the chopper under the rhexis edge contra-incisionally, pull it toward the defective, crush and bisect that heminucleus in half. I do the same maneuver again around the third quadrant, and then hooking the peripheral lens, pulling it centered toward the fricative, and fracturing the lens. Again, because I'm directing the forces towards the center, this is very zonular safe, and I'm using crushing forces that are directed toward the center, which minimizes zonular stress. The biggest stress in these cases, honestly, is really when you're having to turn the lens within the bag too aggressively. But once you remove the pieces, it actually loosened things up, and so there's not much zonular traction in this case at all. And of course, sculpting can cause zonular traction when you're pushing down on the lens, and of course, there's no sculpting with this technique. You saw I got around that fourth quadrant, and I crushed that lens. Again, this is a fairly dense lens, about 3+, and you can feel the tactile density of the lens. But again, you can position the instruments around the lens piece and then crush it with opposing forces, fracturing the lens, doing this over and over again, and then very gently pulsing ultrasonic energy and vacuum to remove the lens pieces. So that's the last piece of the epinucleus. I'm just removing some remnant nuclear pieces so they don't fly out and hide underneath the iris. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. So yeah, you don't ignore those small fragments. You want to go after them as soon as you can, because you don't want those pieces flying underneath the iris and hiding from you. And then later on, you see in post-op, and then you get a nuclear chip in the antechamber. It's not a good idea. So I start subincisionally always for cortical removal, and I always try to go from anterior to posterior. One of the things you're going to start to notice, and this is why I really, really like the polymer tip, I can be pretty confident when I do IA and touching the capsular bag. As you can see when doing these maneuvers, you can sense that there's some zonular laxity as I'm pulling the cortex away from the capsular bag. And as you can see here, I'm pulling that cortex off, but you can see this distinct fold right here that's indicated by this red line. That's that actual edge of the cortex being pulled from the posterior capsule. But then you're going to see a second line, which is actually a fold in the capsular bag that's just proximal to that pulling force. And so you can see it's essentially crumpling up. The capsular bag is crumpling up on itself, causing those two folds. Now I'm removing cortex now on the other side, and as I'm pulling the cortex, you can see there's another fold that's created because of that zonular laxity. So again, knowing how to polish the posterior capsule, knowing how to tease off the cortex from the capsular bag, and recognizing these subtle hints that there's zonular laxity are very, very helpful. And there's only one way that you know this is by doing these maneuvers. So again, with the polymer tip, I feel very confident cleaning the capsular bag. You saw that those are very fine pieces of cortex. A lot of people would have just left it alone. But you can see here as I'm polishing the posterior capsule, you see it's puckering up, it's collapsing. The capsular bag is kind of collapsing into the INA port. As I was doing the IA and removing the cortical material, even before that, I could just sense that there was some looseness of the zonules. And again, unless you do these maneuvers, you can't sense that at all. You're doing the technique and you're really disassociating yourself from any knowledge of zonular strength. And so polishing and doing these maneuvers really give you a better idea of the zonular strength. And that's why I love to do these maneuvers for all of my cases. So you saw I did BSS and I pulsed it into the subincisional capsulorhexis. It was nice and clean. Now I'm going to push some cohesive viscoelastic to fill the bag. I turn the water off. That's another thing that I'm doing now. I turn the water off before I come out, because when you have water going in and you push the viscoelastic, it just shoots the viscoelastic out of the eye. And so I turn irrigation off, keep the INA tip in the eye to keep the chamber formed, and then I push the cohesive into the bag. You can see now I'm polishing with the sweep, and as I do this, you can see there's fine wispy material coming out from the subincisional capsulorhexis. Again, the sweep is really, really nice. It really helps me look at every nook and cranny and make sure I'm able to clean up the bag thoroughly as possible. And now you can see I'm sweeping from the other side, and you're seeing the same thing. You're seeing quite a bit of cortical material that's coming out from in the subincisional capsulorhexis. Certainly I can use bimanual, but in this way I don't have to switch instruments. And so now this is a CTR. One tip that I have, take it out of that little indentation where that little case is, because it's hard to put the injector inside that hole and it'll pop out. So you lift it up out of there, you're in the same plane, and then you're able to engage that eyelet with the CTR injector. And so you can see here now it's fully engaged. I have full plunger control this way. And again, by lifting it out of the inset of that case, lifting it up higher, you're able to hook it in the same plane, and it's less likely to pop off when you're trying to engage the CTR with the injector. So that's an important pearl. So I like to lift the incision with the Sinsky hook, and then I go through a limbal incision 90 degrees away. I hook the leading eyelet, and I advance the CTR. As I do this, I minimize torsional stress onto the capsular bag when I do this, and then I pop the trailing eyelet down into the bag, and then that's it. I lost some viscoelastic in the process, so I'm pushing some more cohesive to fill the bag, and then I go ahead and place the injector in. This is a single piece acrylic lens that's going into the capsular bag. You have to quickly transition to the INA handpiece, activate irrigation, make sure I address any reverse pupillary block, lifting the pupil, disengaging the haptics off the optic, going underneath the optic, tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag, trying to get rid of all that wispy stuff that might be in there, any potential lens material as well. Oftentimes there's very fine lens material there, so I switch to polish mode and try to get rid of that stuff as well. So again, it's really nice using the foot pedal to be able to switch modes very quickly with this machine. Once I'm done polishing, I switch to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a 3+ dense lens. The lens tilted a little bit when I performed double chop, but because all the forces are directed towards the center, and then even though the lens tilted, it stayed in that same position. It just rotated within the capsular bag, so it didn't cause any zonular problems. While I was doing IA, I really sensed, and cortical removal, I sensed there was some zonulopathy. When I'm pulling the cortex from the bag, you can just get a good idea. And again, polishing the posterior capsule really helps with that. So I think this is something that everyone should really do, especially if you have the polymer tip. And then you saw my technique on placing the CTR in. I like to use a Sinsky hook to hook the leading eyelet, and so as it's being advanced, it's able to dial into the bag without causing too much zonular stress. And then I'm able to hydrate my incisions. You can see this is a perfectly centered lens into the capsular bag based upon all the techniques that I do every time when I do cataract surgery. This patient had, again, zonular disease. Who knows down the road if this patient has a dislocated lens? Thankfully, because there's a CTR, I'd be able to lasso the CTR with some suture and anchor it to the scleral wall, and I wouldn't have to do a big surgery like a lens exchange in this case. And again, hopefully it doesn't ever happen, but I feel like the CTR in this situation just provides insurance down the road so that I can protect this patient and resecure the lens if it ever dislocates. So I hope this was helpful to you, and I thank you for your attention.